Well, hello and welcome to the Well After Hours. I am your host, Beverly Allen, and I am looking forward to our conversation today to be helpful and hopeful on the topic of cancer care and the African American and Black community. And while this conversation is going to be beneficial for everyone and every viewer, I am particularly targeting in on that group because they have the highest rates of getting cancer and dying from many kinds of cancers. And that's why I'm so happy to have my very special guest today, who is an oncologist and much more that I will tell you about, Dr. Sheldon L. Holder. Dr. Holder, thank you so much for coming to the Well.
Thank you for having me and for allowing me to come talk with you in this forum. I'm excited to talk about it too.
Uh, and I'm so glad. And I want to just tell the viewers a little bit about yourself. I know I had your bio in the opening, but we go by a little too fast for them to actually read the whole entire thing. So I'm just going to give them a couple of notes from your bio. Dr. Sheldon L. Holder, MD, PhD, is a physician scientist in the Cancer Center at Brown University. He is an assistant professor in the Department of Pathology and Laboratory Medicine at Brown University and an attending physician in the Division of Hematology Oncology at the Lifespan Cancer Institute. Dr. Holder obtained his Bachelor of Science degree from Oakwood University and his MD and PhD degrees from Loma Linda University, with a PhD in microbiology and molecular genetics with Dr. Michael Lilly. He completed internal medicine residency training at the Penn State Milton S. Hershey Medical Center and hematology oncology fellowship training at the Vanderbilt Ingram Comprehensive Cancer Center. Dr. Holder maintains an active research laboratory where he studies novel targets for cancer therapy, with a particular focus on P1M1 kinase. Am I saying that right? I'm not sure. Kinase?
It's kinase.
Kinase, okay. As a therapeutic cancer target. He also maintains an active oncology clinic where he treats patients with genitourinary malignancies. Is that right?
Yep, you got that right.
My goodness. Oh, some of those medical terms can really be tongue twisters. But Dr. Holder, I am so glad that you were able to carve out some time to be with us today. And we're going to get into some questions. But before we do, would you just explain the scope of your specialization in the field of oncology?
Sure. So I'm a medical oncologist, and what that means is I'm the kind of physician that treats cancer patients with medications. So broadly, when we treat cancer, we're frequently using either surgery or radiation or medications. And each of those modalities are delivered by different kinds of specialists. So I'm the kind of specialist that uses medications. So I'm a medical oncologist. And when we train to treat essentially all malignancies. But at academic medical centers, usually, and at mine, oncologists tend to focus on a few tumor types. And so, as you said earlier on, I focus on patients with genitourinary malignancies. That essentially means kidney, bladder, and prostate cancer for the most part. So those are the patients that I'm seeing.
Well, thank you so much, because I know people sometimes get confused, when there's a cancer diagnosis, and it seems like now every hospital has some cancer division, and your doctor refers you, your
Right.
primary care doctor will refer you. And sometimes I think they feel they may have to stick with that particular doctor. But can you talk about a few of the options, or how a patient should navigate at the initial diagnosis of a cancer?
Sure. That's a real tough part for patients because you're going from your general physician, whether that's your family doctor or an internist or someone like that, or maybe even your OB/GYN physician, and you're going to be referred to a specialist. And it's somewhat hard to say how best to navigate that, because some of that is probably dictated by people's insurance. Sometimes your insurance gives you better coverage within a network. And so you may be, if you're basing your decision on coverage, you may have a less broad group of oncologists to choose from, depending on what your insurance is. So usually they will refer you, your primary physician will refer you to an oncologist within that your insurance covers well. And that is something that people should consider because oncology care is expensive. And so having good coverage from your insurance provider is something to consider. And so that's one thing. You can look maybe at your provider's website or even contact your insurance provider's kind of customer service on the back of the card, and you can ask them what oncology services are within network in your area. So your provider, your primary care provider, might refer you to a hospital, that's a mile down the street. But maybe there's another hospital that's 5 miles away or 10 miles away that's also within network. And maybe you like an oncology provider there better and they're still within network. And so you can check your own for yourself to see what your options are. So I think that's probably where I would start.
That's a good place. That's so helpful. And, I know there are barriers sometimes, especially in the African American, and Black communities, as to the types of treatment that may be available that they may not be aware of. What is it that Black people particularly should know when they are told they have cancer?
Oh, wow, that's a packed question. A cancer diagnosis is a really difficult thing. It's a life-changing diagnosis, frequently for the patient and for their family members, whether that's spouses or children or parents, and so it's a really big deal. I think part of that answer also depends on the personality of the person who's being diagnosed. So some people want to know all the information possible, and some people on the other end of the spectrum feel too overwhelmed to know all the information and really only want to know the essentials and kind of just do what the doctor recommends without having to know all the details. And I think we as providers, I say me, should respect the level of details that patients want to have. But I think as a patient, you should know that you have the right, you have the ability to get as much detail as you want, right? And I think that's the main thing that I would want to get across to patients who are being first newly diagnosed with cancer. You can get as much or as little information as you want. So if your provider, if your oncologist doesn't give you the amount of information you want, then you should ask for more, or you can seek out information from other trusted sources. But don't be afraid to ask your oncologist for more. I've had patients where I give my initial discussion about their cancer, and patients would ask me to tell them more information. I usually come in down the middle, and not too much or not too little. I try to, and I've had patients say, you don't even need to tell me more, just tell me what to do. And I've had patients say, oh, I really would like more information. Can you give me information? Is there literature you can give me? Is there a website where I can go? So I think patients really should advocate for getting the amount that they want. And even if that means they want less, but definitely if they want more, ask for more information.
I know that there is a part that racism plays in the disparities within the African American and Black communities. How can a African American or Black person feel comfortable with what not just the diagnosis, but with the recommended care?
Yeah. You bring up a very good point, right? So there's certainly, within the Black community, there are several layers, right, of bias that we probably should talk about. And that bias exists in a lot of places. So maybe we'll work through it. So, there's definitely some patient bias, right? So we as patients, we may have bias against the system, right? Because maybe we have personal history with the medical system that makes us not trust the medical system, or maybe that's cultural and it comes down from our parents or our grandparents or our great-grandparents. There's a culture of not trusting the medical community, and as a member of the medical community, we've earned that distrust. We have earned that, and as a member of the medical community, it's our responsibility to try and fix that. But as a patient, I think that you should at least understand your level of lack of trust, right? And where that comes from. And then I think the hard part is figuring out, can I trust this person in front of me, right? This provider that's talking to me about what my treatment should be, can I trust that person? So I'm a big advocate for second opinions. My patients will frequently ask me for a second opinion, and I tell them I don't feel slighted, I don't feel upset, I'm not, nervous or worried about them seeking a second opinion. I fully support second opinions. I think what that does is it helps build trust. And if the patient decides to see me or to see the other person, that's fine with me. I have no problem with that. And so if you don't really trust the person in front of you, ask them for a second opinion. Ask them to send your information to a nearby oncologist, outside that group, and see what that person says. I regularly send my patients' information with their permission, to another oncologist. And sometimes, they've already identified who that oncologist is, and they say, yes, I want to go to such and such a place. And we send that information to them. So I think that's one way of helping with the patient bias. Get a second opinion and then see what that person says. Then outside the patient's control, there are lots of other things that contribute to the biases. There, of course, can be provider bias, right? So providers might give less aggressive treatment or spend less time with certain patients. And that's frequently unconscious to the provider, I think. But that doesn't make it not true just because it's unconscious. And so there's that level of bias. And then there's some bias that's in the system. It's just in the system. I think you mentioned some of that. And so that's biases that occur because of the structure of the system, right? The medical system and the way in which it's structured in the United States. So this could involve things like access to care. So, many people have access to care based on their insurance. And for most people, their insurance is based on their employment. So your ability to access care is based on your employment. And that's probably not a fully equitable method of doing that, right? And so sometimes people have good access, they don't have good access, they don't have good transportation to get to the place where they can get the most comprehensive care. Their job is such a job that they can't get time off to go get that kind of care. So there are lots of things in the system that might impact some populations more than others, just because of where those populations exist. That's regionally, like by zip code, and that's also, let's say, hierarchy within socioeconomic status. Now, all of those things come into play. So there are lots of biases that come into play and will determine the doctor that's in front of you when you finally arrive at the oncologist's office. So I hope that answers your question.
Well, it certainly was very helpful. It's a start where, where to go from. And it shows that I like what you said when you said about a second opinion, because sometimes people are intimidated to say to their doctor, I would like a second opinion. Nothing personal, but I would like to, know in my own mind that, there's a confirmation in this, and I guess it could be a little awkward if one doctor is saying one way to treat it and another doctor is saying there's another way, because I guess there are multiple ways of treating things. I mean, because there's new advancements coming out, every year,
Yeah,
somehow.
that's absolutely true. Sometimes the best way to treat a cancer is clear. Sometimes there is, clearly one way that's better than all the other options. But sometimes it is kind of a gray area, and one way may be as good as another, and like maybe a surgery is as good as radiation, and you can do either one. And your oncologist might say that one is as good as the other, which one you want to do. Or your oncologist might say, I think you should do surgery, but you could do radiation, or I think you should do radiation, but you could do surgery. And so the second opinion, as you said, helps to kind of differentiate. And, I think that, it's good for patients to remember that, we call it the practice of medicine for a reason, right? It's not like math where 2 plus 2 is always 4. Right? And so there is a level of uncertainty when a physician tells a patient, this is what I think you should do, right? Because none of us know the future, right? And that information is based on, so me making a recommendation to a patient is based on what I know about that patient, but it's also based on applying what I know about that patient to maybe tens or hundreds or thousands of other patients that have had similar cancers, right? But every person's an individual, right? And so we don't know enough to 100% accurately predict the future to say this is the best treatment for you. And so sometimes 2 different oncologists will come to 2 different conclusions and say they would do one thing and the other oncologist will say they would do something different. And I don't think that necessarily means that one oncologist is wrong. It has to do with evaluating the data in front of you and kind of synthesizing that into a recommendation for the person in front of you. And sometimes there's a lot of gray areas in there, which you have to decide as the oncologist which way you're going to go. And so I think it helps if patients remember that it's the practice of medicine. We don't know the future. We base a lot of things off of statistics and personal experience and published data. There's things like that. And so I wouldn't feel, if I were a patient, talking to a patient, I would say, don't feel discouraged if your second opinion physician doesn't give you the same opinion as the first physician. You really can ask them why they think their opinions differ. And then ultimately, hopefully, you as the patient will feel comfortable with one versus the other. I mean, one treatment versus the other, and maybe even one provider versus the other.
Oh, thank you. That is so good. So when what after they learn, okay, they'll have to decide like which treatment to get. Now, are they given the kind of availability of multiple treatments, or is it only according to what their insurance will provide?
Yeah, good question. So typically what happens is there are treatments for cancer that we say are FDA approved. So if you're in the United States, that stands for the Federal Drug Administration. I forgot the name briefly. Federal Drug Administration, right? So that's a government entity that approves medications and that medications and medical interventions, and that applies to cancer care also. So let's say, for example, when a new drug is available. Let's say a new drug comes out for prostate cancer. At some point in the pathway of development of that drug, the FDA approves that drug for prostate cancer. And when they approve it for prostate cancer, they usually will say the conditions under which they approve it. So maybe it's approved to be given by itself, or it's approved to be given in combination with a second drug. Maybe it's approved to be given as what we call first line, the first drug that you give for prostate cancer. Maybe it's only approved for second line. You have to give something else first. And if that thing stops working, that first treatment stops working, then the drug is available to be used, not as the first line, but as the second line. And so FDA approved interventions, whether that's a drug or radiation or surgery, those tend to be covered by the insurance company. No matter what your insurance company is, usually, because those are considered what we would call standard of care. So it's not experimental, it's proven, and usually the oncologist is recommending the one that kind of the community thinks is the most efficacious, the best to use. So it's going to give you the best chance of cure or control the cancer the most for the longest period of time. Those are usually covered by insurance. Now, some insurances may cover it better than others, but you usually have some degree of coverage. So if it's a pill or a drug, maybe one insurance is going to cover 80% of that cost, and another insurance is going to cover 85%, another insurance is going to cover 70%. So it might depend on the cost, might still differ among insurances, but usually gets some degree of coverage. And then, so the other thing I want to mention, before I go there, so when thinking about treatment options, usually your oncologist will offer treatment options that are FDA approved. I would say they should be offering treatment options that are FDA approved. But sometimes they will also offer what we call a clinical trial. So clinical trials, which we haven't talked about yet, but I am a big proponent of clinical trials. So clinical trials are, I think we probably should change the name because they have a bad rep, particularly within Black communities. And as I said before, we earned that, but we're trying to change that. So clinical trials are the ways in which we figure out if one medication is better than another medication. So if a new drug is available, let's say it's been discovered or it's been developed, and we think it works well for colon cancer, how do we know how well that drug works? If this new drug is drug B and drug A is the current standard of care, the current thing that we would usually use, how do we know which one's better, drug A or drug B? Well, you can do lots of tests on cells like I do in the lab or on smaller organisms, but at some point you have to know whether it's better in humans. And the only way to know that is to actually use it in humans, right? That's the only way you're really going to know. So at some point, you need what we call a clinical trial. Glean as much information as you can prior to the clinical trial. But at some point, you really need to test drug B versus drug A in humans and figure out which one's better. So that's what a clinical trial usually is. We are trying to figure out if one treatment is better or worse than the other treatment. Well, that in most cases, it means the newer treatment. Are we trying to figure out if the newer treatment is better than the older treatment, the old standard, right? That's the way medicine advances. And so clinical trials are a great way for cancer patients or any patient to get access to the newest available therapies. So that's the way I think about them. It's a way to get access to medications that are not even approved by the FDA yet, because we don't know if it's better. But usually it's being offered because there's a lot of work that's been done ahead of time that makes people think, not just one person, but multiple people who are involved, that this drug is going to be better than the older drug. And so it really is the way for patients to get access to the newest and the greatest. And that might be important for cancer patients in particular, right? Because sometimes if you have an incurable cancer, maybe the current drug has been shown to slow down the cancer or stabilize the cancer or prevent growth for 2 years on average, maybe. And And the new drug that's in development might not be available to the general public for 5 years. But you have cancer now. You can't wait 5 years for that drug to be FDA approved, right? And so what a clinical trial does is it allows people to get access to these drugs when they need them and not necessarily wait for FDA approval. I said all of that to say that frequently insurance companies will not cover a drug that's being given under a clinical trial because it hasn't been proven to be better than the standard of care. And so they will frequently say, no, we're not going to pay for that new drug because it hasn't been proven. So when thinking about insurance coverage, frequently the insurance isn't covering treatment under a clinical trial. But we get around that because whoever's funding the clinical trial will usually pay for the treatment under the clinical trial. And so this actually is a way in which people who don't have insurance or have insurances that provide lower levels of coverage can get access to the best drugs. So frequently these are people within Black communities whose insurance maybe doesn't give the best coverage. If you're in a clinical trial, you get the latest and greatest, no matter what your insurance is, because the people funding the trial are paying for that care, right? This is where access comes in, though, because where do we usually do these clinical trials? Well, they're usually done at the big medical centers. Most of the time, that's where they're being done. So usually medical centers associated with a medical school or university, these are the places where those trials get conducted. And sometimes, depending on your location, right, your zip code or your socioeconomic status, it's harder to get into the spaces for treatment. And so that's what we call that system. There's some things built into the system that might prevent people from getting access. So that's one of those things. But I would say, something that's not common within Black communities is, I would say we should start changing the way we behave in that we should ask for clinical trials. So if you're a cancer patient who's newly diagnosed and the doctor gives you a treatment plan and it's not a clinical trial, I would ask them, that sounds like a great plan. Is that standard of care? Can you tell me, are there any clinical trials available for which I would be eligible? And see what they say. They might tell you. So the other thing about clinical trials, I know this is a long answer. I didn't mean for it to be this long.
Take your time.
The other thing about clinical trials is that, as I said, they're offered at specific locations. And so if you're being treated somewhere, different institutions have a different portfolio of clinical trials, because frequently when someone designs a clinical trial, they might say, I need 200 patients in order to answer the question. And so they say, well, I need maybe 5 cancer centers in order to get those 200 patients. And so the study will be opened at 5 cancer centers. And that's the only place in the world where you'll get that therapy, in those 5 places under that trial. And if you're not in one of those 5 places, you can't get that trial until it becomes FDA approved sometime years in the future, right? And so the clinical trial portfolio dictates what the oncologist can offer under a clinical trial. And so frequently in my position, when I'm talking to patients, because I am at an academic medical center, if patients are looking for a clinical trial, I will say to them, these are the trials that I can offer you that we have here. And if none of these are ones that you like, I can refer you to another place that has clinical trials, and their portfolio will be, some of these trials might overlap, but they might have some that we don't, just like we have some that they don't. And so you can refer patients also for the clinical trials that might be available to them somewhere else that you don't have at your location. So that also can impact on what's available to patients.
Boy, I was hoping I was going to get to it, but I'm so glad you brought that up earlier on about the clinical trials, because that's something I think we need to be encouraged to look into, because most people don't really ask about that. And I guess, well, from past history, but also like you said, the name needs to be changed, because it seems like, okay, they're just trying this out on me. They're not really trying to cure my cancer. They're more interested in the drug, but they don't know that the drug is what can help to cure them or give them longevity,
Right.
and that's another point. Everybody wants to be totally healed of cancer.
Right.
And I don't know, some of the, I guess, drugs in the past, or some people's experiences, that they were treated, but they weren't healed. And they want to have a plan A for the treatment, but at plan B, how can I, if you get rid of the cancer, what can I do to fight to keep from getting it back?
Yeah, that's a very good point. So you're absolutely right. A lot of times when we're treating cancer, the question is, can you cure my cancer? Right?
Yeah.
Or are you only able to slow it down? Or are you only able to, kind of stop it from spreading for a finite amount of time? And sometimes that's the case. I would say for many of my patients, I would say for most of my patients, they do have incurable cancer, most of my patients. And so we're talking about, how can I give you the longest quality life I can, right? And that's still important for us to try to do that. And then sometimes patients do have curable disease, and we're aiming to go for that cure. And sometimes we achieve cure, and sometimes we don't. But we're aiming for cure, right? So we will talk about patients' cancer being potentially curative or not being potentially curative. Can you repeat that last part of the question? I forgot.
As far as, like, giving them longevity or being healed.
Yes. So whether or not patients are receiving potentially curative therapy, or therapy that we know is designed to slow the cancer down, or achieve what I call stable disease, meaning the cancer is not growing and spreading for some period of time, lifestyle issues are important. They are definitely important. So the phrase I like, which I borrowed from another physician, was he used to say, it still does, and now I say to my patients, what's good for your heart is good for your cancer. Most people, because the heart doctors did a very good job. Well, let me go back a little further. The number one killer, even today in the United States, is heart attack and stroke, called cardiovascular disease, right? So the number one cause of death in the United States is still cardiovascular disease in adults. So that means cardiovascular disease, heart attacks and strokes, kill more people than all cancers combined. And so for a long time, we have been, as a medical community, trying to decrease death rates from heart attack and stroke. And a lot of research and public service announcements and things, messaging has gone into trying to do that. And some of the ways we've done that are great things. We talk about diet and exercise, right? These are things that you can do to prevent heart attack. Don't be sedentary, stop smoking, not drinking alcohol or drinking less alcohol, being active, eating less fats, or if you're eating some fat, eating the better fats. So if you're eating meats, eating fish and chicken instead of beef and pork. All of those things that most people sort of understand, more fruits and vegetables, less processed foods. Most people understand that as important for heart health. But the truth is, all of those things that I just listed apply to cancer health also. Both in prevention for getting cancer in the first place, to having a diagnosis of cancer and how well that cancer is going to be able to be treated, to having been treated with curative intent and you're in, let's say, remission, and recurrence rates. So there was a big study that came out in colon cancer many years ago. It was probably 10 years ago now, or so by now. And they showed that patients who were treated for curative intent for colon cancer, who had similar treatments, so the same kinds of chemotherapy or surgery, recurrence rates, so the cancer coming back, were lower in patients who were on an exercise program, right? So we used to say, and people still say, if there was a pill that I had that could reduce recurrence rates like that, everybody would be getting that pill. It would be prescribed. But because it was exercise, you can't prescribe exercise, right? And so I think we lose a lot of benefit from that because it's not something I can write on a script or send to your pharmacy and say you have to, you should do this, and your insurance company will pay for the pill. But it can be as effective as a medication, right? So all of those lifestyle issues are very important. And in fact, the American Cancer Society has guidelines that you can find easily on the site of the American Cancer Society, where they recommend some lifestyle recommendations for cancer prevention or in patients who already have a diagnosis of cancer. And they will say those kinds of things. So diet and lifestyle are very important. Yeah.
Wow. Well, will they'll actually, I from listening to some things that I've heard on some research from some doctors have said that there is definitely, like food that can help, like while you're taking the drugs, that can help strengthen your immune system so that you get stronger to fight against any future cancers, like their diets. They've learned certain things, discovering from different foods, unprocessed foods, that the way you eat them can actually help fight cancer. Is the medical community kind of joining up with, like, the nutritional medical community to help, like kind of give cancer a 1-2 punch?
Yeah.
So that while you're taking those drugs, you can,
I think the answer is yes, but probably not as fast or in the way that most people would like us to. There are two different disciplines, but what I would say is I think that I think the reason is because as a system, the medical community that I'm a part of, right? So physicians, we're really focused on treating disease.
Yeah.
That's kind of in the United States where the way medicine is taught, right? We're taught to treat disease. And though there is some prevention that is taught and discussed, the lion's share, the bulk of the treatment and the training is on treating, right? Because we're going to see more sick people than well people, at least as an oncologist, right? I think there are a couple of points I'd like to make. So one is in terms of cancer care, at least, but in lots of other disciplines too, we derive a lot of our therapies actually from nutritional information, right? And so, for example, one might determine that, or just pick it, this is not a real example, but just hypothetically that oranges are good for prostate cancer treatment, right? So what would typically happen is the oncology community might recommend oranges, but ultimately what they're going to try to do is figure out what that active ingredient is in oranges, and then figure out a way to administer that in a controlled way so that certain patients will get a specific dose, right? So, for example, if I say eat 3 navel oranges, well, you might get more or less of the active ingredient depending on the size of the oranges, where the oranges were grown, how they were grown, whether they're from Florida or California. You might have different amounts, right? So if I'm trying to be precise about the amount of medication I'm delivering, the better way to be precise about that is to have it as a pill or have it as an injection, so I can give you 50 milligrams when I know I need 50 milligrams, as opposed to saying, well, the average orange has 25 milligrams, so you need 2 oranges. When in fact, maybe 2 oranges only gave you 40 milligrams instead of 50, right? So that's typically how we have kind of approached giving medications, developing and giving medications for cancer therapy and outside the field of oncology too. But I will say that there is a there is a growing, I would say, understanding among physicians that lifestyle issues are very important, and that some things just can't be prescribed and turned into a medication, like exercise, right? I mean, I actually have had some physicians, in the days when we used to write paper prescriptions, because now everything's electronic, write on a prescription pad, you need to do 30 minutes of exercise 3 days a week, right? Now, whether or not that helps the patient actually do it, as opposed to just saying it to them, writing it on a prescription, maybe that does help to write it on a prescription. But I can't prescribe a pill that does the same thing that 30 minutes of exercise would do, right? And there's probably not one active ingredient in exercise, that does. There's a combination of things that happens in the body when one does physical activity that you can't replicate in a pill, right? And so I think people within the community recognize that, within the medical community. And so there are several things with diet and lifestyle that we encourage, but I think we all recognize that's not our area of expertise. Our actual area of expertise is treatment. So the other point I would make in relation to that is that frequently when patients arrive at my office, right, you arrive at an oncology office, the things that the body does to fight cancer, and maybe I should say this, we know that the body fights off cancer every day, right? There are abnormal cells that are developing in the body that your immune system recognizes and destroys because they're abnormal. And these are probably cancerous or precancerous cells. Patients who have weak immune systems actually are more likely to develop cancer. We know that. And so we know the immune system is surveying the body for these abnormal cells and getting rid of them on a regular basis. And so definitely there's a important component of prevention. But whatever the body normally does to prevent cancer, if you're showing up in my office, your body has already lost that fight, right? So this is what I will frequently tell my patients who ask me similar questions like, should I just go eat more grapes? My answer is no, you shouldn't just go eat more grapes. Now, more grapes are good for you, absolutely, but you shouldn't only just go eat more grapes, because whatever your body's systems are to prevent cancer, it's already lost that fight. You're in my office, you have cancer. And so what we need is something more than what your body's already able to do. Right? Now, it still helps to have strong systems. But what we need to do now is to treat the cancer in such a way that your body is not able to do, because it's already overwhelmed with what your body can do. So the example I gave is if a patient, let's say, has pneumonia, right? The patient shows up in the emergency room with pneumonia and they need supplemental oxygen. So they're not getting enough oxygen, you need an oxygen mask or something, right? I wouldn't tell them go take vitamin C. Although absolutely you need some vitamin C for your immune system to be strong, and that would help you. But at this point in your medical problem, you need something more than vitamin C, right? So we can give you antibiotics, and that will treat the bacteria, if it's caused by a bacteria, that will treat the bacteria that's causing the pneumonia. And then it weakens it enough that your immune system can kind of take over and eradicate it. That absolutely happens. But what you need is something that's gonna knock the pneumonia down, knock the bacteria down, weak enough for the immune system to get the upper hand again. Right? So frequently that's the way in which I envision your body's natural defenses and natural offenses being able to help with cancer care. If you showed up on my doorstep, you need something more. But that doesn't discount what the body is still able to do. So what we ideally like to do is, whether it's surgery, radiation, or some cancer medication, weaken the cancer enough that now you're working together, so that you can still have a strong immune system that's going to help eradicate the cancer. But that's not going to be enough by itself, because then you wouldn't have had cancer in the first place if it was going to be enough by itself, right? So if we can get the two systems, the natural and then let's say the aided systems to work together to eradicate the cancer, or at least make it stable, whichever one we're working towards, then that's really the way I envision those working.
Boy, wow. That is so, I appreciate all that you said. And there's more, but I want to just take not even an intermission. I just want to go to our highlight segment so I can share with
Okay.
the viewers more information about you and, what you're doing. And so don't go away. We'll be right back. We just want to share some information about Dr. Holder and what he's been doing and what he's doing, going to be doing even in the future, should you want to, reach out to him and to contact him. And we'll be right back. So don't go away. There's more. Hello, we're back, and I know you appreciated receiving all that information about Dr. Holder and his work that he does and how you can benefit from it. Which brings me to the point, Dr. Holder, that I wanted to talk to you. I wanted to go back to the thought on clinical trials because of someone I knew who had an experience that clinical trials held them over when there was no other help, that drug helped them to have longevity until they got the other drug, a newer drug that they had been working on, that could take them even further in their cancer battle. And I know that's kind of like the aim.
Yeah, that's a very important thing to consider because, as I think many people probably realize, we have historically, and I would say within the last, 5 to 10 years, been making big advances in cancer therapy with new things, new drugs, new techniques. And I describe them to some of my patients as science fiction, like the things we're doing nowadays. And when we're talking about cancer care, if a patient doesn't have potentially curable disease, and we're talking about trying to suppress the cancer as long as possible, right, and give patients a great quality of life while we're doing that, that frequently means sequencing the drugs in such a way that you keep the cancer under control. And clinical trials are a big part of being able to do that. And it's not infrequent that patients would go from one clinical trial, and then if the drug stops working on that clinical trial, then they go into another clinical trial, and then they go into another clinical trial, and then maybe a drug becomes FDA approved, and so the next time they're not on a trial, but they're getting an FDA approved drug. And then they go back to a clinic. So, what it does is it gives us more tools in the toolbox. Right? Because frequently for cancers, there may only be a few tools. And then if you use those tools up, we don't have anything else to offer the patient. But I can extend my tools and extend the duration of control, hopefully, by being able to use clinical trials. And so that's the other reason when I say, the benefit of clinical trials. I know historically people think about that as being used as an experiment, being used as a guinea pig. And I don't deny that we don't know what the outcome will be. That's the purpose of the clinical trial. That's why we call it a trial. But really the goal is to improve the patient's cancer care by providing a drug that you otherwise would not have been able to have access to, that lots of smart people really think that drug is going to work. And there's good evidence to show that. And I want to highlight within the Black community why this is important. We talked about, so if you think of it as giving you more tools that are available to help treat your cancer, I have done some work in trying to improve diversity within cancer clinical trials. And so I do want to just mention some information. Every year the FDA, we talked about the FDA, this is the government body that approves medications. Every year they put out a report for the drugs that they approved in the prior year. Okay, so in 2023, the FDA approved 13 new oncology drugs, 13 new medications for cancers, 13. And in the United States, you have to have a clinical trial that proves that your drug works in order to get approved. So there were clinical trials that were done to approve these 13 new drugs. Those trials included about 4,500 patients. It was 4,504, according to this public report that you can get from the FDA's website. So out of those 4,504 patients who participated in clinical trials to get 13 drugs approved, how many of those patients do you think were self-identified as Black or as African American? Out of 4,504 patients, 84. 84, that's 2%. So out of the clinical trials that were used to approve the 13 new drugs that became available in 2023 by FDA approval, only 2% of those patients were Black. So this says something about the population of people that were involved in these very important studies, because these are the studies that are going to tell us whether or not the drug work. It also says something about how many Black patients are being treated on clinical trials. These are arguably, one could say, the most important clinical trials, because these are the ones being done to get new drugs approved, right? So what that says to me as a Black oncologist is there are large populations of my cousins and my relatives who are not getting access to, or for some reason are not being treated on these clinical trials. They're not getting access to these new drugs that they otherwise should have been able to get access to, that might have improved their cancer treatment or the longevity of control of their cancer or how well they live with their cancer. They're just not on the trials. And I think that's an inequity that we should fix. And so I've spent some time trying to help us have more Black patients be able to be on clinical trials. And as we've talked about at the top, I think, of our discussion, there are lots of layers that contribute to that. But one thing we've done is we have started a historically Black college and university cancer trials consortium. So we talked about trust being a big issue, right? And so we thought one way in which maybe we can get around the barrier of trust is to have us do our own trials. So what if the HBCUs, the historically Black colleges and universities that have medical centers, what if they offered their own clinical trials? Maybe we would feel more trusting of going and signing up for those than we feel signing up for some other people's clinical trials. And so one thing that we're actively trying to do is bring these, so there are 4 HBCU medical schools at the moment, and there are 2 that two more that are being developed. So what we're trying to do is bring these HBCU cancer programs together so that together we can start to offer some clinical trials. So these are things, so look out for it. There's some things that we are trying to do that I think will make a big impact on numbers wise, the amount of Black patients that are on clinical trials, but much more important than that, individual people who have cancer and need access to better drugs than what's already available. And the way to get that is to have access to the clinical trial portfolios of as many places as you can. And so what I'd love us to do as a community is to encourage each other to find your cancer early by doing your screenings. And then if you're diagnosed with cancer, absolutely talk to your oncologist, get a second opinion, ask them about clinical trials that might be available. If they have none available there, ask them if there's a site somewhere, driving distance, hopefully, to you where that might have clinical trials so they can send you as a second opinion. Sometimes there's not a trial available and all you have is standard of care. Standard of care is great. But if clinical trials are available, to absolutely consider them. This will help us have better cancer outcomes within our community.
Wow. Do you have to be at a stage 4 level in order to get a clinical trial?
Oh, I'm glad you asked that question because I should have stated that earlier. The answer is no. The answer is absolutely not. So most clinical trials are designed for patients with a certain stage of cancer. Some will take all stages. So stage 1 is usually the most curable, and stage 4, in the most typical sense, usually means not curable, but that's not always true. There are some stage 4 cancers that patients are still potentially cured, but the cure rates will be lower in patients who are stage 4 than the patients who are stage 1. But there are trials designed. So for example, when we talk about the clinical trials that we offer, what we like to have is a portfolio that has clinical trials available to everybody in every stage. So there's a trial that's available for people who are stage 1, people who are stage 2, people who are stage 3, and people who are stage 4, and it's usually not the same trial. And that's why we talk about it as a portfolio. So the same way people who do investments make an investment portfolio, and you have some that are, for short-term growth, some of that for long-term growth, and all of those kinds of things, so that together you cover everything. The same thing when we think about our cancer patients as a population. We want everybody, whether you're coming in with stage 1 disease or stage 4 disease or somewhere in the middle, to be able to have access to some sort of clinical trial that's available to you. So a clinical trial, and many years ago, people used to think about clinical trials as a last-ditch effort. Like, you've tried everything, there's nothing else left. Okay, let's try a clinical trial. That's not the way in which we design or think about clinical trials anymore, because we understand that these new drugs are things that are going to help real people. And a lot of those people are people who don't have stage 4 disease. And we can maybe cure more people if we're able to offer these drugs before patients are in stage 4. And so you could have any stage of cancer and be eligible for a clinical trial.
Thank you. That is really helpful, because I think most people think that, you don't go to a clinical trial until you're, at your last wit's end, when there's nothing else. But I'm glad to know that they do have clinical trials for different stages. That is so very helpful. Well, I tell you, I guess we could go on asking question after question, but you've answered so many good questions. And I just was wondering, I would ask you if there is anything else that you would like to say to anyone watching, that you feel, that things are even more, maybe a little more hopeful now than they were certainly years ago. To not give up, that there are things that are available that they may not hear of, and that they can have to be a little bit more proactive in some of their, searches, even if you don't have someone. That's why I want to give all the information. If someone wanted to contact you, where are you, and what is the best way to, contact you for talking more about clinical trials if they're interested?
Sure. So as you said, I am at Brown University's Cancer Center in Providence, Rhode Island. The best way to contact me is to email me, probably. And that email is easy. So my name, I think, is on the screen. So it's just my name, Sheldon_Holder at brown.edu. That's the best way to get me. And I will respond to your email. And hopefully I'll be able to be helpful.
Well, we will make sure we will provide that information to everyone at the end of the show, so that they can reach out to you. And certainly this has been so informative and so helpful in these times when, I don't think there's anyone who may view the show that hasn't been affiliated with someone they knew that had cancer, whether it's a family member, a friend, a coworker, because we hear about it. It has become almost so normalized, and like you said, there are disparities. We know that, but there are also things that we can do within our hands. I mean, like lifestyle changes, things that we have to do, to have a better, outcome, and to help along in the process.
Right.
It's like we say, people say they have faith. I said, but faith without works is dead. You got to put some work along with the faith,
Yes, absolutely.
So that's very helpful. And, I know that you are an elder in your church, and you are actively involved in your church. And when I think about the years of study that you have put in to be where you are and who you are, I said that has to be a calling. I mean, really, to give yourself to, to have a love for what you do, and for the people, you want to help. That's not just normal. It's just not normal. I mean, you can count up the years. I'm like, wow, all this steady, years of, and all the education and everything that you have put into it. We say thank you to our servicemen, but I say thank you to our, medical teams too, for especially in our communities, it's so helpful to see someone at your position who looks like you that we can identify with, that helps us and gives us more trust. And then to learn that the person even is a person of faith, that really kind of solidifies like, okay, because you're at wit's end, you don't know who and you don't know where. So I thank you so much for being on the well and allowing viewers and everyone that sees, I know you're not there just for our community, but you're there if the community needs you, and if anyone needs you. Your credentials speak for itself, and you are an award-winning researcher. I mean, we put that information out there for any late viewers who are just coming on. We're not just sitting here talking to anybody. We're talking to somebody who has done the research and who has been awarded, with the accolades and the things that go along with it to continue to do what he has been doing. So I thank you so much, Dr. Holder. And if there's anything you want to say to anybody, any last closing remarks, I would ask you to make them. And then if I could ask you to please just close us out with a prayer.
Sure. I want to reiterate something that you did say, just for those who are listening. And you said it well. I want to say it again, because it's important. In 2025 and going forward, a cancer diagnosis is not necessarily a death sentence. And even if your cancer is not curable, we have very good treatments that will usually improve your quantity and quality of life. And I encourage everyone listening, if you have a cancer diagnosis or your family member has a cancer diagnosis, that you should at least hear the options. Hear the options from the professional that would treat you. Despite what you might understand cancer to be and cancer treatment to be, a lot has changed, and some things haven't changed. And so the best way to understand is to talk to the oncologist. No one will force you to do any treatment, but at least understand. I've had many patients who have come to me who said they just came because their family member said they should come, and they intended not to be treated and then decided to be treated because the treatments are better and more tolerable than they used to be. And so it may not be as bad as you think in terms of being treated. And so get the information, get a second opinion if you need to or if you want to, and then make a decision after you have the information. The other thing I will say, it's been a privilege being here on the program. Thank you for inviting me. I count it a privilege to be able to, so you talked about this being a calling. I count it a privilege to be able to help people who have very serious medical problems, and it's a privilege to help people that way. Some days are tough. Most days are not as tough as people think. And there's a lot of goodness in helping people be better and feel better. And isn't that what we've been called to do, right? Now, I do that in the field of oncology, but people do that in all sorts of different fields. But I count it a privilege to be able to do it for patients who are sick with cancer. And I agree with you. I think God has called me to do this work, and I feel honored and privileged to be able to do it. And you want me to close with prayer?
Thank you so much. Yes.
Right. Let's pray. Father, thank you for this program, The Well After Hours, for Beverly, who you set up to start it, for the platform that she has, and for the ability that you've given us to talk about cancer care today, in general and within Black communities. We ask that you will use this program and the things we've talked about to improve the lives of people, to make a difference, to penetrate where penetrance is needed, to bring hope and healing and life and love and support which is we know what you do when you show up. And so if you're using this program as a means of showing up, we appreciate that. Continue to use Beverly and myself to reach others for you. In Jesus' name we pray. Amen.
Amen. Amen. Thank you so much. I appreciate it. And I hope you will come back
I will. I
at
will come
some
back.
point in the future. We'll see what's going on and what news is going on in any way that we can help you get the word out too, about what is available. And that's the other thing. I didn't even mention it when we were talking, but I also know that you had made steps to make sure, even through the churches, that people could know about what was available to help in our communities, that you were going around actually, doing the footwork to let people know what was available to them. And so that's so appreciative. And I certainly want the viewers to know that you weren't just sitting in an office, even though if you were, it's still okay because you're still helping people do things, but you were actually interested in reaching out to them, to let them know what was available. So that's so great. So I thank you. And as always, we tell you, you know what, you got to stop by the well. The well is a resource, and God has blessed so many of the guests to come on and to share that information and so much that will be helpful and beneficial and hopeful. So we thank you for being here. We look for you next week, the same time and the same place. And until then, stay well, stay safe. God bless you. Thank you again, Dr. Holder.
Thank you.